the MIC, that minimum inhibitory concentration, is going to drive your drug dosing. So you have to maintain a certain level or a certain dosage above that MIC in order to be able to kill the bacteria. So some drugs are concentration dependent, some are time dependent. We'll give you loading doses for those that are more concentration dependent. So you take twice the dose at such and such time, and then you this much dose and this much dose every time thereafter. And it's to get a maximum concentration within the bloodstream. So the more that you have, the greater the killing power. Those that are time dependent are not dependent upon the concentration. So you can give 10 times, 20 times, 30 times the dose. It's not going to kill it any faster, or it's not going to be any more lethal. It plateaus, but it's important that you maintain a concentration in the blood at all times. So for those, you've got to make sure that they take it every 8 hours or every 12 hours. So when you hear somebody or someone talking about concentration dependent or time dependent, or you're looking at a particular drug and it's time dependent or concentration dependent, you have a better understanding of the importance and the value of it. Are we going to go through that on every single drug we have here? Absolutely not. One, we don't have the time, and two, it's not going to be critical to what you do. But I want you to be aware of the importance that when somebody skips a dose, what that might mean. And when you are looking at the drugs and you realize that it is concentration dependent, you might say, you know what, I might take an extra, I'm not being recorded. Just understand what it means to be concentration and or time dependent in regards to killing.
Do drugs respond? Like, is there, if you're trying to kill a certain infection, do you pick a concentrated versus time, or?
So what you do is that you pick it based on MIC, the sensitivity to the drug. So the question is that, you know, do I pick a drug if it's concentration if it's time? And the answer is no. You want it to be sensitive to the bacteria. Okay? It's always going to drive your decision. Identify indications for each class of antibiotics. So if I talk about gram-positive versus gram-negative, or aerobe or anaerobe, and I highlight it specifically, you should be aware of it. Identify dangerous side effects for each class of antibiotics. So each one's going to have their issues. So when we talk about those side effects, I highlight a side effect, be aware of that side effect. Because of the sheer volume, as we talk about these antibiotics, I'll do the best I can to make sure that I highlight a drug in a class. I'll highlight its particular use as well as its potential side effect. And then mechanisms of resistance that are relevant. One of the things that you will find is resistance is a key player in identifying and treating your patient. If you're on a particular antibiotic, you're 2 days in, it hasn't resolved, or they haven't seemed to improve, it's not, more than likely it's because the antibiotic, there's resistance to it, or it was the wrong one chosen. So start looking for something else. You should see changes relatively quickly when you're talking about infections. So within 24 to 48 hours, you should start to see changes. If not, then we may be talking about resistance. One of the problems that we have is that, and I'm not gonna lie, I'm guilty of this as well, is that we don't always finish our dose or our regime of antibiotics. When we talk to antibiotic resistance, there's a number of different ways that the bacteria can become resistant, but one of those ways is by passing on DNA through plasmids. And what happens is I take a drug, I take it for 2 or 3 days, I start to feel better. I stop taking the drug. I haven't eliminated the bacteria completely. So those bacteria that are there, bless you, they have been exposed to the antibiotic. Some of them may have developed some type of resistance, or at least they've seen what the possibility is, and then they're able to convey that to other bacteria. Okay, so it gets transferred on. Now, does it necessarily mean that you see a secondary wave of infection? Sometimes you do, sometimes you don't. But that bacteria now is going to be present with those changes. So the next time that you are exposed to that same infection and you give that same antibiotic, it's not going to work. You have to dose, not the dose, it's not going to work because it'll be resistant. So when you take the antibiotics, the reason they want you to take it to completion is so that you kill it and you eliminate it. So there's nothing left. There's no siblings, there's no nieces, nephews, nobody that can come back and get you later because they go, oh yeah, that's the bug. Want to eliminate it, completely wipe it out. All right. So what I try to do is break this down to 4 primary categories. As we go through, I've eliminated a couple that I'm not going to talk about today. I'm not going to talk about phosphomycin. It's typically used for, does anybody know what it's typically used for? UTIs. Phosphomycin.
Oh, it's not even highlighted. Okay.
Yeah, and I also removed chloramphenicol too. Maybe a few others, sulfonamide. Just because as I was going through it, it's going to be impossible to talk about all of these in an hour.
What was the other one you covered?
Chloramphenicol,
No, the other one after that. I mean,
sulfonamide.
So it's not related.
No. As we go through it, I highlight the ones in red that you'll see. I hope by exam 4, you come to realize I am not going to trick you. If I highlight something in red or I tell you that you need to know it, then it's going to show up again. I'm not going to pull something randomly and ask you a question that you haven't been exposed to or that wasn't talked about in some form or fashion. So as we go through the slides, as we have these drugs there, focus on the ones I tell you to focus on. It's either because they are the most commonly used or they were used and no longer are used, and I want you to be aware of that. Depending upon where you practice, I'm hoping that everybody's up to date. But what you will find is that people will continue to use the drugs that they were trained on. So you've got somebody that's been in practice for 20 years and they're still using the same drugs. We've talked about the reasons behind this, right? And some of it is that when a new drug comes out, why do we not use it right away? Well, you don't know what side effects are. So you wait for somebody else to kind of work that out. And it's usually people in a teaching institution. But you can also get into a habit where I'm overwhelmed by the number of patients that I have and that I just can't keep up with all of the new drugs out. And some physicians will simply stick to what they know. Average physician knows about 10 drugs. If they tell you they don't, try it, you can challenge them. I've done it on a couple occasions and 10 is usually a good number. It's not always even as many as 10. And it's not good or bad, understanding that they are typically focused with a particular area and that's what they see and that's where they practice. I say this so that you understand why things may change. So part of what I talk to you guys and what I teach you is that, hey, this may be the drugs now, this might be a drug that you're seeing, this is the drugs that are coming, so that you are aware, because you will more than likely be more up to date than they will be. The last time they had a pharmacology lecture was their 2nd year of medical school. Otherwise, it's people that are coming in and selling them the drugs. It's the salesmen. Empirical versus directed therapy. So I've touched on this already. You can read the definitions, but I wanted you to understand that when the causative agent is undetermined, we typically use a broad spectrum. Once we identify what the actual bug is, then we will focus our treatment. Bacteriostatic versus bactericidal, right? So bacteria divide by fission, limited number of resources, and they absolutely increase logarithmically. Bacteriostatic means that you inhibit this process, this replication process, so that you no longer have an increase in the number of bacteria. You stop the reproduction, right? It doesn't otherwise kill them, it just stops them from reproducing. So given time, they die. And it moves on. They may usually take a little bit longer, but they also have a post effect, meaning that they hang around, so that if you did only take the drug for X amount of number of days, that it will continue to work for several days past that. And it's typically because of their mechanism of action. If I was to alter protein synthesis, I alter DNA replication, it may take a day before you start to see it truly become effective. But because DNA replication and protein synthesis is something that takes time, that when you stop taking that drug, well, you've already suppressed the protein synthesis and the DNA replication, so it will linger for a period of time beyond that. Which means that you maintain the colony at a certain concentration, and the body's doing the job and doing the work of killing it. And a bactericidal, yeah, it just kills it. Just kills it. Would you ever combine 2 antibiotics at the same time?
Maybe.
Maybe?
If they're targeted.
Okay.
If you're not using like broad ones.
Okay. Heard somebody from the back that wanted to say something. They don't want to say anything anymore. Okay. Absolutely. We used multiple drugs all the time. Sometimes it's because there's resistance, so we will combine drugs to prevent resistance. Amoxicillin and clavulanic acid. Amoxicillin develops resistance because of beta-lactamase, and we add clavulanic acid, which prevents that or destroys that, so it doesn't. The resistance to amoxicillin is eliminated. So sometimes we use antibiotics and non-antibiotics together, so the antibiotic will work. Other times we'll use combination antibiotics in order to make sure that we kill the bug. So drug combination therapy actually reduces the probability of developing resistance, treats infections due to more than one pathogen, so you'll see multiple antibiotics. Examples include intradermal infections caused by aerobic and anaerobic organisms. So sometimes you've got both. One may be overwhelming, or one may be new, so you can use with multiple treatments. I actually have to take that out. It just defines what it is. Additive versus synergistic versus different. Okay, so minimum inhibitory concentration is the lowest concentration of drug that prevents visible growth following 24-hour incubation. Okay, so I give a drug and I get no growth. Okay. Low MIC infers greater sensitivity of that bacterium to that drug. So the lower MIC, it's the more potent that drug is for that bug. Can I compare MICs of different drugs? So amoxicillin, vancomycin, tetracycline, they have an MIC of X. Can I compare them across, between?
I guess it
So-
just depends on how high the infection is. Depends on what you're trying.
And my question is actually a trick question. You don't compare them across drugs, you compare the MIC to a bug. So whatever the MIC is for that bug, because tetracycline's MIC is going to be different for one bug versus another bug versus another bug. So you're always comparing the MIC within the bacteria. I say that because as we talk about targeting our therapy, our directed therapy, they're gonna target it based on MIC. So whoever has the lowest MIC for that bug is gonna get the call. Come on up, it's your turn, okay? Because it's showing that the drug is more sensitive, therefore it's gonna be more potent, yeah.
So how is that not comparing drug to drug?
It's comparing the MIC of drugs inside of a bug, not.
I hear
Yes.
you.
Yes,
but
my
now
point was that it's, the MIC can vary
per bug.
So what I don't want you to think of is that, oh, tetracycline is really potent for this drug. It's got a low bug for this bug, so I should use it for this bug and this bug and this bug compared to another antibiotic. Because that
Outside of that bug.
because it will vary. Okay, based on the bug. Does that make sense?
Yeah.
Okay.
I was just pointing at the
No, absolutely, and I appreciate it because I will tell you that it's an important point, and it was something that I didn't always stress, and it came back, you know, when students would tell me, well, I didn't understand, you know, why, I always thought that this was the most potent antibiotic. What do you mean? Well, it had the lowest MIC. Again, I would say, so what do you mean?
It's not fixed.
Correct. It had the lowest MIC for this bug, that's why it was used. That MIC is going to change based on the bug.
So you have to test like every bug to know.
So you're going to based on what the problem is, right? So there's only certain bacteria that produce pulmonary infections, only certain ones that do GI, that do X, Y, or Z. Once they identify where the infection is, they're able to at least believe or come to an idea of which bug it might be. Then you know which drugs are most effective.
Okay.
And you take that drug and you can ablate it. And that's how they do it. They literally put the bug on a plate, petri dish, and then they'll put little spots, little areas of the drug, and then they look to see who's got the minimum, who has the inhibitory rings. If the bacteria grows, it's not effective. If it's dead, then it's effective. Now we have to determine what the effective concentration is. Okay.
Then while they're doing all that, they have you on a broad spectrum.
Typically. So ideally speaking, and I say this because I mentioned in the beginning, I talked about concentration dependent and time dependent, right? And I put this slide in just to make sure that you understand that if you do have a concentration dependent drug, that doesn't mean that you just ramp it up to as high as you possibly can, okay? Because there is toxicity. So ideally, with those drugs, when you start talking about their effectiveness, they're going to be looking at their toxicity. They'll be looking at their toxicity, and it's a toxicity that will determine what that drug dosage would be. Okay.
So toxicity times what?
What that dose will be for the concentration dependent drugs. They may say, listen, you can double the dose, or you're gonna take this amount for 3 days and then decrease. They want to get as much drug into your system as quickly as possible without you experiencing the toxic side effects. Okay? And concentration dependence is you need to maintain that at a set level. So the most important thing in understanding those drugs in order to be effective beyond the MIC is half-life. We're not going to talk about half-life of these drugs today. You won't ever have to do that. You don't have to worry about it. So there's no reason to extend a conversation on half-life. But what I'll tell you is that they want to make sure that you stay above a certain concentration, and the only way they can do that is with half-life, knowing the half-life. That determines 6 hours, 8 hours. So a couple quick points about the pharmacokinetics. Peak serum concentration should be about 4 to 10 times the minimum inhibitory concentration to kill the organism. So for those that are time dependent, you wanna keep it above that the entire time. Okay, you wanna keep it above that the entire time. Problem comes in when somebody has a narrow range, when their toxicity compared to the MIC might be 10 or 11 of a drug. Then you've got to question whether or not you need to use that drug. Sites of infection and how easy is it or difficult is it to deliver? Believe it or not, based on the disease, that you may be able to get drugs into a particular organ or tissue more easily when they are infected than when they're not. Routes of elimination may determine use as well. So if it's eliminated by the kidneys and you have kidney dysfunction, then you're not going to be, you won't be treating with that particular drug. Drug allergies as well as host factors. So certain drug allergies, as we know with penicillin, you'll hear I'm allergic to penicillin. It's rare, less than 1%, that individuals actually show an allergy or a reaction to penicillin on first dose. They have to be exposed to it first. So what do? If they suspect or if they're concerned, they can do a quick skin test. They prick you, see whether or not you develop a wheel or a reaction. All right. So what are the host factors that are in play? The immune system. So alcohol, diabetes, HIV, malnutrition, all of them will alter the immune system. Genetic factors. Classic one is G6PD deficiency. Pregnancy and lactation, age. You've got to account for age. Renal function as well as liver function.
What do these all affect? Just like how you're gonna
Dose.
Oh, like how much dosage you're gonna need to actually kill the antibiotic. I mean,
Yep.
kill the bacteria.
So everyone in this room is at a wonderful age. So you can take a certain concentration of the drug and you're fine. As you get older, you may not be able to take as large of a concentration of the drug. My toxicity level is going to start to narrow. I may not be able to clear the drug as quickly or metabolize it as fast. So that has to be taken into consideration. So I would decrease the dose. Unlike pain medications where you can escalate the dose and say, oh, I take more of that medication, I feel better. You have to ask yourself, why do you have different dosages of antibiotics? This is why. Because otherwise I should just be able to give everybody the same dose and it works just fine. But when you have other variations, genetic, immune system, age, renal, or liver function, then it can change the amount of drug that you need, one, to be effective, and two, to be safe. Okay? Resistance. Oh, wait, I messed that up. Okay. I had 5 slides on resistance. I love talking about resistance. I realized we're not doing 5 slides. We're doing 1. So I'm going to tell you what they are, and then as we go through it, I'll mention them. And say, oh, this is how it's resistant, or that's how it's resistant. Sometimes I won't. Changes in microbes or ability to resist treatment by antimicrobial drugs. This often happens in microbes as exposed to concentrations that are less than suboptimal. So either concentration wasn't high enough or prolonged exposure to the antibiotic. So I keep giving the antibiotic. And one last one is, I shouldn't say that. The exposed to concentrations that are suboptimal, that are suboptimal, that goes to I didn't take it long enough. Or I loaded up on drugs from Mexico. Everybody does it here, right? Okay.
What kind of drugs?
Antibiotics. Okay, no tequila for you. And what you do is you keep it in your cabinet. Every time you get the sniffles, you don't feel good, you take 2 or 3 days of the antibiotic. Anybody ever do that?
I know people that do it, but not me.
Okay, good. That's how you develop the resistance. All right. Mechanisms: inactivation of the drug by bacterial enzymes. So we'll talk about beta-lactamases in a minute. But production of beta-lactamases versus beta-lactam rings in penicillin, where it actually destroys the beta-lactam ring. So the beta-lactam is no longer effective. decreased drug accumulation via increased efflux or decreased permeability and uptake. You see some of this in the antibiotics. You really see, what you see is a decrease in permeability. For some of your gram negatives, the way the drugs get through is through porins. So what they'll do is that they decrease the number of porins. So less drug is able to penetrate the cell and destroy the cell. You see efflux issues less in bacteria and more in our cancer drugs. So you'll see that all the time, where they change and increase the efflux, where the drug's not actually able to get to penetrate because it'll bind and it gets kicked back out. And that's not uncommon with a lot of our various types of developed tumors. Microbes develop altered receptors or metabolic pathways for the drug. Vancomycin, or I'm sorry, not vancomycin, but MRSA, vancomycin resistant MRSA, is really cool. I'd love to spend a long time talking about it. But what actually happens is that the binding site for vancomycin is a very specific location within a transpeptidase. It's dealanine, so it binds to that and essentially prevents the cross-bridging from happening. And when we talk about vancomycin resistant bugs, they've changed the dealanine to D-lactate. So they're still able to form these outer membranes, but vancomycin no longer has a binding site because it's looking for dealanine, and now they've substituted with D-lactate, so it doesn't exist. Genetic mutations as well as plasmids. So plasmids can pass on the resistance. So those that you do not kill, they remember, and they send it to the next generation, and it goes after those bacteria, and or I should say, it goes after those drugs when you try to treat it. So preventions of resistance: use antibiotics only when absolutely required. What kills me is that you have a bacterial infection, typically we run 5 to 7 days. At day 3, you're sick and tired of being sick. So you want to go get a prescription. So you're going to start at late day 3, maybe even day 4. Don't. You're not going to die. Because the amount of time that it takes for that antibiotic to kick in and start working is the same amount of time that it's going to run its course, and the body will take care of it. So don't expose the bacteria to the antibiotic, especially not in your system. Now, it's easier said than done, especially if we have children, right? You see them sick, they're crying, you can't get anything done, they're miserable, you're miserable, all you want to do is sleep. You don't care. 1 day, 2 days, 3 days in, you're on the antibiotic. The worst thing is, and I'm not gonna lie to you, I've done this before, and you show up, you have a viral infection, they write a prescription for an antibiotic. You fill it, you hold it and wait. Okay? Don't do that.
Why wouldn't they just give steroids?
So does a steroid actually, does it fight off the infection?
I don't know, but you feel a lot better. That's what I'm saying. If the
You're absolutely right,
antibiotic
you do
isn't
feel a
gonna
lot
do
better.
anything, why not just give the steroid to feel
Oh,
better?
and okay, so the problem with the steroid is, and you're right, you do feel better. But do you remember how steroids work? Anybody? That was in and out?
Did we go over that? It must have been on like the first or second test, Dr.
Yeah, it was.
Last week?
After protein synthesis?
When you have an infection, the cell gets broken down into 18 carbon chains. Right? It gets destroyed. So the body doesn't want to have to remake everything. It's got to reuse what it's got. So it takes that and breaks it down and then reuses it. Well, when it's due to infection versus trauma or normal apoptosis, the body recognizes that and it recognizes it as an infection. Cyclooxygenase pathway, lipoxygenase pathway. So it sends a signal to the body to say, hey, we've got a problem. That's the lipoxygenase pathway, right? That's the increase in cytokines and the bronchospasms and everything else. So, I'm sorry, not broncho, well, Ken. On the cyclooxygenase side, fever, pain, right? So I take it, I feel better. Have I done anything to the actual bug?
Yeah.
Mm-mm. I've just blocked that pathway, so the fever and the pain goes away. I don't have the bronchospasm either. I don't have the increase in the cytokines, so I feel better. But again, I haven't done anything to the bug. By giving, one of the side effects of steroids is increased risk of systemic infections, because you're suppressing the immune system, because those pathways are set up in order to magnify the inflammatory process. But the inflammatory process makes you feel bad, right? It's a protective mechanism. Sleep, stay home, drink juices. But you don't. So by taking the steroids, you feel better. Quick tidbit, and I'm gonna move on because I don't think I told you guys this. Anybody know why we always say you have to stay home or you need to be fever-free for 24 hours before you return to work? How do you know?
Because the virus is trying to fight it.
The fever is
It's
trying to
trying to
kill
kill
the bacteria.
So, what typically happens when you do have an infection in the morning? You wake up, how do you feel?
Feel better than at night.
Feel better in the morning than you do at night. You know why?
Because when you're resting, your body's fighting.
No. When do you see, I want to put, this is important because it really goes to your understanding of patients too. When's the worst asthma attacks usually occur?
No.
Right. So the worst asthma attacks occur at night and you feel the best in the morning. The reason is that your cortisol levels are the lowest at night and the highest in the morning. Cortisol is a steroid. So when you wake up in the morning, you suppress the immune system, you feel good. So you don't have a fever. I'm going to work. I go to work, by 2 o'clock I feel like crap. I need to leave and go home. Because the cortisol levels are coming down and they'll continue, they're diurnal. So by the nighttime, they're at the lowest. So 6, 7 o'clock, you get achy again, you get the fever and you just don't feel good. My child, when he had asthma, my son had asthma as a kid, and if he looked off at 4 or 5 o'clock in the afternoon, I hit him with steroids. I load him up and I wouldn't stop with the steroids because I knew I'd be in the emergency room at 2 o'clock in the morning. Because as it starts to fall, it rears its ugly head. And then if the inflammation's there, I can't get out of it. Okay, make sense? All right. So gram-positive versus gram-negative. Your gram-positive is going to have it doesn't have that outer membrane that the gram-negative does. The gram-negative is the one that we typically think of when we think about those, the porins and the efflux. Think of it as a harder shell. Okay. We have 10 minutes.
How do we have 10 minutes?
Because I've got to walk over to the other building in order for another class.
Okay. You can just tell us what you're gonna ask on the test. We'll let you go.
Don't we have another lecture day with this?
We have one, you guys?
Yeah.
We have 2 more.
No, we have one more next
Yeah.
Monday.
Yeah.
That's it?
That's it. I may just give you an extension of this and touch on antifungals. Because antifungals are important and not do antivirals. Antivirals is relatively straightforward. There's only a handful of them out there. I'll give you the breakdown on the antivirals that you need to start that within 24 hours or it's not effective. But I don't want to rush this. I want to make sure we spend time enough. I'll go back and talk about the end of the asthma lecture too. So we'll do asthma and tie into this. So next week I'll modify what's on your syllabus. This is just a lot of information. And Do you know what 60% of the drugs that are prescribed in the hospital are? Okay. So we're going to talk about cell wall inhibition. So how's a cell wall made? I had some real cute animation. I couldn't get rid of this part. I wanted to get rid of it so I could move through faster than I could, so I'm just going to quickly pop through. So the proteins that make that bacterial wall, we'll call them NAG and NAM, because if I ask you to say N-acetylglucosamine or N-acetyluramic acid, it's more difficult to commit that to memory. But if I say NAG and NAM, we're good?
Mm-hmm.
All right, NAGya, NAMya, okay. All right, so the way this works is that you have cross-bridging that takes place with amino acids. It's usually 5 amino acids that we're going to attach to the NAG. And then you have an enzyme, transpeptidase, or penicillin binding protein, that comes in and cleaves these two here, leaving a really nice cross bridge. Okay? And as you create more and more of these, you have a very tight outer shell. That is what we're targeting when we talk about targeting the beta-lactams. The beta-lactams actually hydrolyze this bond here. They don't prevent it from binding, they actually hydrolyze it, bond, and destroy it. So what you have is that you have an active cell or an active bacteria, and it comes in and it starts to cleave this, and the cell can no longer maintain its integrity. So it lyses. Bactericidal or bacteriostatic?
This is the static. No, the
one that kills it.
Yeah,
The
the
second
side.
one.
It kills it. Because this is already an active bacteria, and by doing this, it kills that bacteria because it's no longer able to maintain its integrity. So your penicillins, your beta-lactams, they're bactericidal, not bacteriostatic. Typically those that change protein formation, the ribosomes, those are bacteriostatic. Those that actually go in and do the killing are bactericidal. So you should start to feel better, not immediately, but after the first dose or two, okay? Because you're eliminating the bacteria. All right, so we're going to talk about our cell wall inhibitors, and more than likely, this is all we're going to get through today. And the rest of them are a whole lot easier. It's going to be it's not as complicated, and you'll have the information so you can look at it when you can't sleep at night, because that's what I'll be covering next week. Put you to bed. You don't need the benzos. This will put you to sleep. But these are the ones that you hear and see and are used all the time. Okay, when we talk to the critical care areas, that's going to be a little different. We got to get a little nastier with some of these, but generally speaking, these are the ones that you're going to encounter quite a bit. So the first one of these groups is the penicillins. Okay, bactericidal, especially for gram-positive. Prevents cell wall synthesis by preventing cross-linking. Poorly penetrates blood-brain barrier except during times of infection and inflammation, when we can see the MIC go down. Actively excreted unchanged in the kidneys, doses should be reduced in severe renal disease. It's not toxic to animal cells, they don't have cell wall. So, since I have just a little bit more time now, I want to kind of pass this on because I think this was quite interesting. The penicillin was originally invented and identified because it's unchanged in the kidneys. This was a world changer. Okay, we didn't have antibiotics, really good antibiotics before penicillin. So this is World War II. And I say this because there's a couple things that you should know. One is that because it's excreted unchanged, it was a very difficult process to make. Okay, it was complicated. So they didn't have penicillin readily available for everybody, but when you had wounds, any types of infection, this would work great. Do you know what they did to the soldiers that were receiving this? Collect their urine, strain the urine, and reutilize the penicillin. Now, this is where some of these, and we're going to talk about this later. This is where some of the myths come in. You can't take amoxicillin and have a beer or a glass of wine. Sorry, for those of you that might be a little more refined. The reason for that was because the servicemen at the time, right, when they would go off on leave, they get drunk, pick up venereal diseases, come back, treat with penicillin. So the people in the field that have potentially mortal wounds, we don't got no penicillin because we're treating everybody that was coming back from leave. So what did they tell them?
Don't drink on your own.
Don't drink. So then they were afraid to drink if they were on penicillin, right? So that was the way they curtailed their activities. I say that because you will find out that what you hear, what you think, and sometimes what's even promoted when it comes to certain drugs is not always 100% accurate. I don't want to bash Big Pharma, because without Big Pharma we don't have the drugs that we do, but they're out to make money. So they will oftentimes put a spin on it. And if the physician or if the sales rep modifies or doesn't completely understand how things actually work, you might get some false information, some misinformation. I will tell you that, probably 60% of the calls that I get from family and friends, can I or can I not do this? 60% of the time I tell them you can absolutely do it.
So why did you say don't drink wine or drink whatever with
You
amoxicillin?
can,
So
but
you don't get scurvy.
Scurvy is a vitamin C deficiency. That's if you take long trips and you don't have access to fresh fruits and vegetables. No. They would say that you can't. The old myth was that you couldn't drink and take your antibiotics or penicillins. So you can. It doesn't affect it.
On all antibiotics? You
No
Oh.
penicillins.
Oh.
We'll get to the other ones. There are some you actually can't, but I'll let you know who they are. Okay. Naturally occurring is penicillin G. It's very narrow focused. It's very susceptible to beta lactamases, and beta lactamases destroy the beta lactam ring, which makes it unusable. Because of resistance and to increase the spectrum, these are typically gram positive. In order to make them more effective on gram negatives, what they did was that they reduced the size of the actual molecule. So your aminopenicillins and your pseudopenicillins, your piperacillin, they're very small molecules compared to your vancomycins and your original penicillins. And that way they were able to penetrate that outer wall. The problem though with those is that they do become more susceptible to the beta lactamases. And what we do is, what we do is that we combine them with other drugs that inhibit the beta lactamases, drugs that are not antibiotics. They're not antibiotics. How many of you have taken amoxicillin or had a family member take amoxicillin?
Mm-hmm.
Okay. Has anyone taken amoxicillin with clavulanic acid?
Would not know.
It's
Well, we know that.
I forget the name of the drug is someone can look it up for me. Amoxicillin, clavulanic acid. I can't remember the trade name. When you hear it, you'll know it. It works. It's extremely effective, but the problem is it also causes nausea. It's not a pleasant drug. Augmentin. Have you heard of augmentin?
What do they use it for to treat in combination?
When if you're looking for a broad spectrum, okay, so is this directed therapy or empirical therapy? Empirical therapy is I'm trying to identify what it might be. I'm giving them a broad spectrum in that bug, they may be susceptible to beta-lactamase, which means that there's a resistance there. I want to prevent that resistance from occurring. So I still give you amoxicillin, which is a great broad spectrum antibiotic. Great. But I want to make sure it works. I act on it.
And what does that do to beta-lactamase?
It destroys beta-lactamase. So the amoxicillin didn't do its job. So that's a combination of an antibiotic and a non-antibiotic. Okay. Allergies. So again, about I think it's 6 to 8% of the population has true allergies to penicillin. They've never taken it. The likelihood that I'm allergic. Well, how do you know? Well, I'm allergic. Have you ever taken it? No. They say no, then they probably not allergic. They have to be exposed to it before they actually demonstrate any type of infection. So additional problems can be superinfections caused by candida, diarrhea, especially with ampicillin, less common with amoxicillin, and you can get some hemolysis as well as nephritis. Drug interactions, this is what I was talking to, sorry, not really. Ampicillin and other broad spectrum antibiotics may decrease the effectiveness of oral contraceptives. So you need to be aware of that. All right, so this isn't a myth. It will absolutely decrease the effectiveness of oral contraceptives.
I have a nephew who is,
Pregnant because of that?
no,
Not
he's here because
Oh,
of
he's
that.
So which ones should I take if I'm trying to avoid getting pregnant?
He's joking.
No, he's not talking about him. He's talking about his significant other.
Oh.
I'm pretty close to someone that could get pregnant.
I don't know if I quite understand that, but
I was
We're not doing this.
not actually for me.
so definitely your penicillins.
Okay.
Those are the ones that are most commonly prescribed. What I'll do is I can't think of all of them off the top of my head because they have a few of them that go outside of this as well. So I will provide you a list. Those that you can take with alcohol and those that you cannot take with alcohol and those that decrease the effectiveness of oral contraceptives. It won't be a test type of question, but it's for your edification.
Yeah.
Okay, the last thing we're going to talk about today is the cephalosporins. Broad spectrum beta-lactam bactericidal. Alternatives to penicillin, when there's resistance to penicillin, should not be used as the first choice unless the organism is known to be sensitive. So I'm going to show you this in a second. What's nice about this is that they have a broader spectrum than some of the penicillins, and then they're not always combined with other drugs. So you can be for your gram positives is your first generation, and those are typically the ones that you give for like before you go to the dentist. Sometimes they go amoxicillin as well before you go to the dentist's office, or before you go to surgery. They may give you a first generation cephalosporin, and then it broadens its spectrum, becoming more gram negative. Third generation is quite potent. Third and fourth generation, and we try not to use them unless you absolutely need to. So allergies, 10 to 20% of patients with penicillin allergies actually have a crossover. About 10 to 20%. Okay, so 6 to 8% of the population has a penicillin allergy. Of those 6 to 8%, say 20% has a crossover. Nephritis, acute renal failure, thrombophlebitis, superinfections, and GI upset.
What is thrombophlebitis? Phlebitis?
Veins, so you get clots in the veins. This is a list of the drugs that you'll be responsible for: first generation, second generation, and what they're used for. First generation, surgery, prophylaxis, and UTIs. Cefalozin, cephalexin. Second generation has more gram negative. Oftentimes used for upper respiratory infections, has some antiaerobic activity, cefuroximine. Third is probably the greatest when it comes to gram-negative and broad spectrum. Reserves for most serious infections and resistance to most other drugs. So cefotaxime and ceftriaxone. Ceftriaxone is the one that is given IV. Cefotaxime is the one that is given orally. There's actually 5 generations. I didn't mention the 5th generation. Oh no, I did.
You said it next.
Okay, good. I was gonna say because I ran out and I was like, it's important but not as important. Cefepime is also 4th generation with better gram positive than your 3rd generation. And then citrulline is indicated for MRSA. I will point out there's going to be 3 that can be used for MRSA. Okay, you've got to know it. You should know. MRSA can be it's a booger to treat and to manage, whether it's systemic and or topical, because it's oftentimes it can be picked up in a number of different ways, but it's a big problem. And I want you to be aware of it because you're going to see it. And I also want you to be aware of it so that you don't ever forget what happens with when we have resistance. We saw this with COVID-19. It's not going to be the next big thing that kills us is not going to be a nuclear weapon. Everybody's afraid of pushing that button. As many nuclear weapons as we have, and as many times as we can blow this world up, nobody uses it. They use targeted strikes, right? What is going to get us is going to be bugs. There was a period of time, almost 20 years, where we stopped working on antibiotics. We are way behind. Bacteria didn't. We are still behind and forever chasing them. We will run out of drugs that we will be able to use for infections. So you'll get sick, you'll have an infection, and you'll die from the infection. So as we talk about this, I want you to be aware why we tell you not to use certain things, antibiotics at particular times so you don't develop resistance. And then just as importantly, I don't want you to forget about those bugs that are out there that are extremely difficult to kill and how common they are, how quickly you can pick that up. Okay. All right, so we're going to end on cephalosporins. And next week we'll pick up on that and I'll do a short version of antifungals and that'll be it.